This is Chapter 10, Airway Management and Oxygenation. So the term ventilation means basically the process of air moving in and out of the lungs, and respiration is the exchange of gases at the cellular level. So you have these two patients here. You have this one young lady having an asthma attack. And because of the bronchoconstriction caused by her medical problem, the resistance inside of her lungs has increased dramatically, and it's a lot harder for her to breathe in to get air down into her alveoli. So her body starts to use accessory muscles. Now, the accessory muscles she's using are skeletal muscles, just like if you ran a marathon or rode a bicycle or went skiing or went for a swim. The same skeletal muscles need oxygen, and they also need glucose to function. So if she doesn't get some type of resolution with this, if she doesn't take her inhaler or go to the emergency room and get treated, eventually her muscles are going to fail. They're no longer going to be able to contract, thereby no longer going to be able for her to cause her chest to rise and fall. And this is not an uncommon situation with asthmatics as well as other types of respiratory distress patients, is they eventually get so tired they just stop breathing, and then a few minutes later their heart stops. So it's really important that we understand that this increased resistance inside the bronchial tubes is basically wearing this person out, stressing them to the point where they run out of energy and they stop breathing. And this is why we need aggressive treatment and transport with these patients. Assist them with their MDI inhalers, possibly bag valve mask ventilations, possibly even CPAP. Now, on the other side of this gentleman here was shot during a drug deal gone bad, and he has a gunshot wound to his right upper quadrant of his abdomen, and which unfortunately that's where your liver is, as you probably remember from the anatomy. The liver's been punctured. He's bleeding internally. So even though his lungs are clear, there's no bronchoconstriction. There's plenty of air getting into the alveolar sac. There's plenty of oxygen available. The problem is because his blood pressure is dropping and because he's losing blood, he doesn't have the red blood cells to carry that oxygen to his body in significant quantities to be effective. So he is now hypoxic because he's losing blood. She became hypoxic because she just couldn't breathe deeply enough and effectively enough to maintain proper oxygenation. Both of these are problems. They both have pretty much the same solution for us anyway in the field. Treat them symptomatically. They need high flow oxygen. They need rapid transport to some type of advanced medical care. Now, the term hypoxia, as you might remember, the definition is inadequate amount of oxygen into the tissues. Now, there's early signs and there's late signs. What usually happens is your chemoreceptors, remember the central chemoreceptor measures carbon dioxide levels, and the peripheral ones measure the oxygen levels, and they also measure pH levels as well. When someone gets into this early stages of respiratory distress or whatever's causing their hypoxia, the chemoreceptors recognize this pretty quickly and they begin the mechanism of supporting the patient's life. And they compensate. One of the ways they compensate is they increase the heart rate. So they release adrenaline. Adrenaline causes the heart rate to increase, also increases the contractility of the heart, which makes the heart beat harder. So harder and faster just means more blood coming out. The patient becomes tachypnic, which means they start breathing faster than normal. And within some relative range, you can breathe 22 times a minute, 24 times a minute, and it's still effective. You're still getting adequate tidal volume. And this sensation of rapid breathing makes the person feel like they're short of breath. And when someone calls, they'll say, I feel like I can't catch my breath. I feel like I'm short of breath. And the reason why they have this sensation is because the body has involuntarily increased the respiratory rate to the point where it's somewhat uncomfortable for them. And this is the definition of dyspnea. Dyspnea is the sensation of shortness of breath caused by this early response to this hypoxic state for whatever reason it was caused. Now, because adrenaline plays a role in all this, um, you get pale, cool skins, and you're probably going to get all sweaty skins as well, possibly. And these are all side effects of that adrenal response. You might get some early confusion or disorientation because remember, the brain is probably the most sensitive organ to hypoxia. And within minutes of hypoxia developing, the person will get somewhat confused, slow to respond, disoriented possibly. They can still answer your questions, but they're just not, as sharp as you would expect them to be. Now, obviously, if you look at these early signs and symptoms, they could be confused for other things. But if you put it all together with their presentation of accessory muscles and maybe their history or what happened to them, might clue you into the fact that they are hypoxic. Now, as this progresses and maybe there's no intervention, we don't get there in time, or they don't call in a timely manner, or they're out in the woods somewhere, whatever, they start getting into this late stages of hypoxia. It's essentially all that stuff in the early box, but everything just gets worse. Their heart rate gets faster, their breathing gets faster, and now it's to the point where the breathing is no longer effective. Their tidal volume has been affected to the point where they're not getting enough breath in with each inhalation. Their dyspnea increases, the feeling of shortness of breath increases. They're now pale, cold, and sweaty, possibly. And what you might notice is that in the very late stages, that tachycardia, that heart rate that's high, starts to slow down. And the reason why it does that is because the heart is hurting, it's lacking oxygen itself. Because remember, the heart itself is a muscle, and all these muscles need oxygen. And so the heart starts to slow down, starts becoming bradycardic. And that's below 60 beats per minute. So, and this is when you start seeing cyanosis. And cyanosis is that abnormal color of blue. It's a blue skin. It's caused by hypoxic blood. Or the term hypoxemia is low oxygen in the blood. And when the person has hypoxemia developing, which of course is connected with hypoxia, with the tissues themselves, you start seeing the change of color of the blood. It darkens the color of the blood, leading to this bluish tint to their face, their lips, their fingernail beds, all those places you might see cyanosis. Cyanosis is a late sign. It means they're moderately to severely hypoxic. Seizures can occur because if the brain gets so hypoxic, it can start to misfire and malfunction, and this irregular, disorganized cascade of cells will cause seizure activity, shaking, and things like that. And then eventually they can go to the point where they're completely altered, where they're not even speaking to you. They can even go unconscious at later stages. And eventually, if this isn't somehow supported or controlled or taken care of, they'll stop breathing, like I mentioned with the asthmatic girl, and they'll die from cardiac arrest. The heart will just stop from the hypoxia. Now, as you've already learned, ABCs, so you do your scene size up, you approach the patient, you get your initial impression of the patient. How are they sitting? Are their eyes open? Are their eyes closed? Do they appear to be breathing? What do their skins look like? All these things you can see from 10 feet away as you're walking towards the patient. We introduce ourselves if that's appropriate for the situation. We try to find out what their mental status is, how they're reacting to us. And while we're doing this, we're assessing their airway. Is their airway open? Are they talking to us? If their airway isn't open, if they're not talking to us, then we have to manually open their airway and support their airway. Now, I know you've gone through your CPR classes and you learned head tilt chin lift maneuver, and it's for people who are medical patients who have no suspected spinal injury. What you do when you provide a head tilt chin lift maneuver is you're aligning the airway. You can see from the arrows when someone's laying in a neutral position like you see on the left, their airway's not aligned. It's probably it's just kind of at a right angle. If you take those two fingers and place it under the chin and the palm of your hand on their forehead, and you tilt that head back, and this is for adults, all the ways back as far as you can safely go, you're aligning the oral pharynx with the trachea, and it gets a clean shot. What it also does is it helps to move the tongue away from the back of the throat. So again, it opens a clear passageway down into the lungs. So you look into the airway, get the airway open. If this person has a potential for a spinal injury, you already know that you would then instead use a jaw thrust maneuver. The head stays neutral, and you use your thumb and fingers to provide kind of a scissor technique where it displaces the jaw anteriorly. And remember, the tongue is actually attached to the lower jaw, the mandible. And when you displace the mandible anteriorly, you pulls the tongue forward. Now, with pediatrics, what's happened over the last couple of years is we've gotten away from doing any head tilt chin lift on any pediatric, whether it's a medical or trauma. We're doing jaw thrusts on all pediatrics, especially if we're doing bag valve mask ventilations. What we're stressing here, and you'll learn more about this when we talk about pediatrics later on in the semester, but when you learn about this, is usually as professional rescuers, as EMTs, as firefighters, you'll have partners. And if we need to do bag valve mask ventilations on a child, it's a two-person procedure. One person is holding the mask and maintaining the jaw thrust while the other person is ventilating the patient. And no matter what it is, whether it's medical or trauma, whether you are ventilating or not, if this child is unresponsive and you need to open their airway, use a jaw thrust. It's most effective for the child, and especially again with the bag valve mask ventilations. You can see if you do have time, or we usually do always have time to do this, but you can see by placing some padding under the shoulders of the child, it gets that child's head and neck into that neutral position that you really need to provide that proper jaw thrust. So get your partner to go grab a blanket from the bathroom of the house you're in, or maybe a blanket off the gurney or the ambulance, something like that, to provide that little bit of lift to create that difference that you need. That will definitely greatly increase your ventilations, the quality of them anyway. So you have the airway open in some way, whether it's jaw thrust or head tilt chin lift. You then open the mouth and you look inside the mouth. There's various ways of doing this. Officially, your textbook talks about the cross-fingered technique. You can see there's some problems with this. If the person is semi-conscious, if they have blood in their mouth, if they have dentures or they have braces, things are sharp in there, they could bite. You could get your fingers cut, and then now you have some kind of exposure. So, but this is, people do use this in the field, but there's other ways I'll show you in the lab, different safer ways possibly. So you open the airway, you open the mouth, and what you're looking for is, of course, is there any vomitus or secretions in the upper airway? Now, if you hear gurgling, that could be blood, it could be vomitus, it could be oral secretions, saliva. You hear gurgling, they need suctioning. If you hear snoring respirations, that means the tongue is partially fallen back on the back of the throat, and maybe your head tilt chin lift or jaw thrust isn't as effective as you think. You might want to try to reposition the head, possibly get a second try at that to try to improve that. You can roll the person on their side into a lateral position, as long as there's no spinal complications, obviously, to get that tongue to fall forward away from the back of the throat. And there's some adjuncts we can insert, an oral pharyngeal airway or a nasal pharyngeal airway, which you'll learn about here in a couple of minutes, where you can insert those to help supplement that, keeping that tongue off the back of the throat. Now, crowing is a high-pitched cawing sound. It comes from the top of the larynx, and you hear this primarily with young children who have croup-like cough or some type of upper airway infection going on. Stridor sounds also come from around the larynx as well. These are associated with things like allergic reactions, some type of inhalation of smoke or gas, someone who's been maybe in a house fire, they've been exposed to high heat, they breathe in that high heat, it damages the tissues around the larynx and it causes swelling. That swelling narrows the airway, creating that stridorous high-pitched sound. Any kind of abnormal sound in the upper airway is not a good thing. Snoring can be fixed in the sense that we can move the tongue away from the back of the throat by various maneuvers or adjuncts. Crowing can be helped by using different types of oxygen inhalation with saline, which I'll show you here in a few minutes. Gurgling, of course, you can suction, and stridorous sounds, especially if it's an allergic reaction, EMTs could then provide the epinephrine pen, which would help to reduce that swelling caused by the allergic reaction, which would reduce the stridorous sounds in the upper airway. So these all can be addressed in one way or another as EMTs in the field once they're recognized. If you do need a suction, the escort suction is probably the one you'll see out in the field most commonly. There are other ones out there. Your agency will train you on the one that they use, but this is pretty much what you'll see in the county of San Diego anyway. There's a flexible tip catheter. They come in various sizes. They fit in the nose, they fit in the mouth, and if necessary, if you're working with a paramedic or you're working in a hospital setting, you can also suction advanced airways like an endotracheal tube. Rigid tip catheters, those are those kind of like that crooked shaped thing right there. That's only for the mouth, and of course there's your suction tubing, 6 feet long, and it works with either of the catheters. Now, when it comes to inserting these, first thing, if we are providing oral suctioning, we never want to place any catheter, whether it's the French tip or whether it's the rigid tip, past the base of the tongue. So we always just go to the base of the tongue and then apply suctioning on the way out. You never want to suction longer than 15 seconds for adults, and you want to try to alternate. So try to do 15 seconds of suctioning and then try to reoxygenate the patient for a few minutes. This might not work with all patients. The amount of vomitus in their airway might be so much that you might just have to alternate more quickly than that, but this is the ideal situation. If you want to suction the nasal pharynx, the nose, then you take a French tip soft catheter and you measure from the tip of the nose to what's called the tragus of the ear. It's that little bump in the front part of your ear right there. That's your measurement, and you would insert it to that point, and then you'd apply suctioning for 15 seconds as you're pulling it out of the nose slowly. Now, I talked about airway adjuncts. So again, if you have a person who's unresponsive, they cannot control their own airway, you've opened the airway, head tilt, chin lift, or jaw thrust, whatever works for this patient, it's not enough. It doesn't provide enough assistance. We can incorporate an adjunct. The first one is an oral pharyngeal airway. So you can see these come in various sizes. They have, I think, about 6 or 7 different sizes, all the way from neonate all the way to really big adult. And so we have to measure these. And how you measure them is you measure them from the front of the teeth to the angle of the jaw, just as you see in the picture right there. It should be an approximation. And also, just the way in the picture is the way it winds up in the person's anatomy. So we're going to open the airway, we're going to open the mouth. We've already measured the device, and then we're going to place this at a 90-degree angle, so perpendicular to the midline of the body. We're going to slide it, the tip of this, down into the mouth, past the soft palate, and then we're going to rotate this until the tip of this is facing down towards the feet, and the flange, it's just the T flange on top, is resting on the person's teeth or gums. Now, obviously, this goes way down past their tongue. So one thing they can't have is they cannot have a gag reflex. So if the person is completely unresponsive to painful stimuli, they probably don't have a gag reflex. It's really the only contraindication for this device. Give it a try. If as you go to insert it, they start to gag or retch, well, then you know automatically that this is the wrong device for them, and they move on to plan B possibly. Plan B is the nasopharyngeal airway. Now, candidates for this device, drug overdoses, stroke patients, maybe an alcoholic, unresponsive alcohol overdose, and they have snoring respirations, and you can't fix the snoring respirations just by opening the airway normally. They need a little bit of an assist here. These people can be semi-conscious. They can be responsive. They can be responsive to painful stimuli, because this probably will not stimulate their gag reflex. They can have a gag reflex. If it's not sized correctly, it could extend far enough down to simulate a gag reflex, but if it's done properly, it's pretty benign. So how you measure this is, you can see that green tube right there. That's pretty indicative of the normal type you'll see out there. On the end of it, there's a flute, and then on the end that's closest to the nose, there's a little bevel, and as an opening right there. So we want to lubricate this device with water-soluble lubricant, like a KY jelly product. We're going to measure from the tip of the nose to the tragus of the ear, the same measurement we did with the suction catheter up the nose. And once it's lubricated, we're going to go into the right side nair first. It's the straightest and the easiest one to get into. And we're going to place the bevel, the opening, towards the septum. The septum is the tissue that divides the two nairs. It's the line between the two nostrils. Bevel towards the septum, and you would slide this carefully all the way back until the flute, that flared part at the end, touches the nose. Then you would reopen the airway. Now, there are people that maybe they have nose rings or nose studs, or they have some type of issue with the right side of their nostril, some kind of deviation to their septum or something. You can then try it on the left side. The difference is that you want the bevel to always be facing towards the septum. So you'd have to flip this device upside down until the bevel's touching the septum, and then slide it in. And then as you're sliding in, you would rotate it down to follow the anatomical curve of the airway. Same process. And again, this is people that are semi-conscious. They have a gag reflex. Someone like a Narcan wake-up person, overdose on heroin, is an excellent device for them. Someone who's drunk, someone who's stroked out, someone who's delirious possibly would work pretty well. Contraindication-wise, primarily because it goes up the nose, we're concerned about facial injuries, especially massive deformities to the face from facial trauma, or skull fracture, because if the bones are displaced or broken, this could actually wind up going up into the brain or into a sinus cavity rather than back into the back of the throat. So if you have any kind of major facial trauma, any type of suspected head injury, but especially a basilar skull fracture, those will be contraindications. So we have the airway open. We've inserted an adjunct as necessary. So we have a patent airway. Now let's check and see if they're breathing. Now, if a person is sitting there talking to you, ABCs are pretty darn quick. Their airway's open, they're talking to you, you can watch their breathing. If they have enough breath to say hi to you, they're probably breathing somewhat adequately. Then all you have to worry about is like, what's their pulse feel like? If the person's unresponsive or they can't speak to you because their breathing is so labored, or they're breathing in very brief, breathing so much or so hard that they can only speak in brief sentences, then what I like to do is I like to take out my stethoscope and I like to listen to their lung sounds immediately during their primary assessment. And if you think about it, if you listen to the lung sounds, this takes you about 20 seconds to do it, or maybe even 10 seconds or less to do it. You're going to get their lung sounds, what's going on inside their lungs, sound-wise anyway. You're going to be able to count their respirations, and you're going to be able to determine their tidal volume. So all in about 10 seconds of listening to lung sounds, you can get a really good idea of how bad off this patient is. How deeply are they breathing? How fast are they breathing? And do you hear anything that you shouldn't really be hearing, essentially? Now you can look at the rise and fall of the chest. You can count the respirations. You can put your hand on their chest or put the patient's hand on their chest or whatever. That's great. But ultimately, if this person has severe respiratory distress for whatever reason, whether it's trauma or medical, I like to listen to the lung sounds immediately upon arrival. Because again, that's going to tell you, it'll give you all your information you need right then and there in about 10, 15 seconds or so. So we listen for abnormal airway sounds. Now, normally, if you listen to someone's healthy lungs, what you hear essentially is air moving in and out. It's kind of like air flowing through a tunnel. It gets that wind tunnel kind of effect essentially. If you're not hearing anything, so either one or two things have happened here. One, you're not using your stethoscope correctly, or this person has bronchoconstriction to the point where they're no longer moving air very effectively. Wheezes are caused by things like asthma attacks, allergic reactions, exposure to chemicals. Cardiac wheezes are common as well. Rhonchi is a loud bubbly sound caused by usually infection or aspiration of food or food product. Rails and crackles are kind of a crackly sound heard in the base of the lungs, initially anyway. And that can be from congestive heart failure as well as a drowning victim. All of these abnormal lung sounds are just that. They're abnormal. They should not be there. And don't be surprised you hear a mixture of these sounds. You'll go to a person who has emphysema, chronic bronchitis, congestive heart failure. You're going to hear wheezes, you're going to hear crackles, you're going to hear rhonchi, you're going to have all kinds of stuff. The point is that as long as you recognize that doesn't sound right, then you're going in the right direction. You don't have to recognize exactly what you're hearing, initially anyway, just that it shouldn't be there. What can I do to help fix this problem? Now, like with anything that you do, if you're working on your car or your motorcycle or your bicycle or your washing machine, whatever, you need to know what the settings are that's normal. That way you can discover what's abnormal. And these are just some numbers that I have no idea who came up with these numbers in all honesty, but these are the normal ranges of respiratory rates that are within normal limits. 8 to 24 for kids, it's 18 to 37. You can see on the screen. And along with the rate, we also look at the quality of their breathing. And by quality, I mean, is it unlabored? Is it effortless? Is it good rise and fall of the chest? Good tidal volume? Is it effective, essentially? So if you have their breathing rate somewhere close to being within these normal limits, and they're breathing unlabored, it's adequate, they're talking in full sentences, you could probably say this person has not having a problem breathing. Now, another thing that we try to put on the patient during that initial primary assessment as well, especially if they do have a complaint of respiratory distress, or you are concerned about their breathing or their oxygen saturation. You would put a pulse oximeter on them. Now, pulse oximeters, they go on the finger, as you can see also on little kids on the toe. I've seen them on clips on the ears as well. Depends on what device your agency uses. But what it does is it samples the amount of oxygen molecules that are attached to each red blood cell that passes by this sensor. And it gives you an average. So if it reads 98%, what it's saying is that an average of 98% of all hemoglobin sites are occupied with oxygen on this person at this moment. So you arrive on scene, you talk to the patient, you get their ABCs, you listen to their lung sounds, you attach the pulse oximeter, and within about 30-45 seconds, you have a pretty good idea of what's going on with this patient. Maybe consider talking to your partner about applying some oxygen to supplement this person's hypoxia. Now, pulse oximeters are just tools. They can be misused, they can be fooled. Pulse oximeters are not accurate in the presence of high carbon monoxide levels or in the presence of cyanide. Both can skew this device, making it think that everything's just fine when in fact it isn't. And one of the drawbacks to our pulse oximeters that we use in the field is they can only read to 100%. And people can actually hypersaturate up to 150, even 160%, which can be a concern for certain patients, that we don't really want that much oxygen in their system. So even though their sats read 100%, they're probably, I'm guessing, they're probably a little more than that. You see this with people who are going through panic attacks. You get there, they're hyperventilating, they're having some kind of emotional breakdown, and they're breathing really hard, really deep, and really fast, and their saturations are 100%. Well, I'm guessing if you were able to somehow sample their blood and take it to a lab and actually find their blood gases, it's probably going to be well over 100%. So 100% is not normal for humans to be on average. And of course, if they have, they're in a state of shock, they have fingernail polish or fake fingernails, or they have cold extremities, these can all affect the device. Remember, this is just a device, and you should, basically assess your patient, not the device. The device is just a tool that can be used in your assessment. Now, when it comes to oxygen therapy, so oxygen, of course, has great positive effects on the human body. We need it to create energy in our cells, along with glucose, to make our body function. So we need oxygen. But oxygen that is in really high concentration in our bloodstream, this is above 100%. What happens is oxygen at high concentrations is a vasoconstrictor. So it makes your blood vessels smaller, tighter. So let's say you're having a stroke, or let's say you're having a heart attack. Both strokes and heart attacks, in the clinical sense anyway, have the same mechanism. You have a clot formation in an artery in your brain, or a clot formation in your artery in your heart, and it's causing constriction of the blood vessels because of this clot. If you have someone having a stroke or a heart attack, and you give them super high concentrations of oxygen, you're actually making those arteries smaller in their brain and smaller in their heart. So you're actually increasing the blockage that's causing the problem. So we don't want to promote vasoconstriction in people with heart attacks and strokes for obvious reasons. People who are in cardiac arrest, people with really critical injuries or critical illnesses, they can actually go into this state of excessive free radical production. Now, free radicals, when your body uses an oxygen molecule for energy, it strips one of the electrons off of the atom, and it uses that for the energy. Well, that creates a free radical. This now has it's a wobbly it's a wobbly atom essentially, and it wobbles off looking to grab another electron somewhere else. And this is a normal process. This happens to your body all the time, every day. And according to the experts, this is what promotes the aging process. If we didn't have free radical production, we probably wouldn't age as much or as fast. But in certain circumstances, especially in patients who are in cardiac arrest, who are revived, get a pulse back, what happens is they have this all this toxic blood and this high concentrations of carbon dioxide, and what happens essentially is they create an unhealthy free radical cascade. So these free radicals fly around and they're grabbing electrons from everywhere, and they cause tissue damage, and they cause swelling, and they cause organ failure in these massive concentrations of free radicals. So we don't want to promote that. And one of the ways we prevent that promotion is we don't hyperoxygenate most patients who don't need it, because hyperoxygenation, having that oxygen saturation of 130, 140, 150% is what really promotes this. So we want to try to avoid that in most cases anyway. So even though this isn't set in stone, but this gives you an idea. So if you have a person with has a mild status trauma patient, a medical person, maybe they have the flu, or maybe they have some type of respiratory infection or other infection going on, maybe they're septic or something like that. If their oxygen saturations are greater than 90, they're 94% or greater, you can withhold oxygen on them if you think that's appropriate for them. If their saturations are below 94%, we would like to provide just enough oxygen to maintain their saturations between 94 to 98%. So you get their baseline room air oxygen saturation. Let's say it's 92% on room air during your primary assessment, and you apply just enough oxygen, maybe via a nasal cannula, to bump that up to 94, 95%, and that's fine. That's where we want to be essentially. This would be like a heart attack patient. You go on scene. A person's having a heart attack. The saturations are 91%. You put them on a nasal cannula, bump that to 95%, and that's fine. That's perfect. Stroke patient would be the same thing. You can kind of even asthmatic patients with oxygen saturations above 90%. You can give them a cannula, see what happens. If they don't improve, then you can bump up. It's called titration, essentially. We start out low and we move up higher and higher oxygenation until we reach that target of 94 to 98%. Now, there are always exceptions. There's exceptions to the rule. Most people with chronic bronchitis or emphysema, this would be the COPD patients, they normally are between 88 to 92%. This is their normal range. They're probably on HOMO2 themselves. They already have a nasal cannula at home at 2 or 3 liters per minute. So if they don't have any severe respiratory distress, some new onset, really severe condition, we just keep them at that 88 to 92%. That's more than adequate for them. Keep them on their 2 liters per minute. If you have to, bump it to 3 liters or 4 liters, whatever it is, to maintain that lower rating for them, because that's their normal norm, basically. Pregnant patients, even though this pregnant patient is maybe she twisted her ankle and she has to go to the hospital, and because she's 9 months pregnant, we're going to lay her on her side, left lateral position on the gurney, as you probably might have learned about already. We're going to put her on maybe a nasal cannula at a couple liters, because remember, she's breathing for 2. There's much more, there's a higher oxygen demand in her body. So even though her saturations are fine, 98%, 97%, 2 liters will actually help her, because she's going to be laying there on her side. It's a little harder to breathe with all that weight of the child and laying on her side and all that. Any patient who's in shock, they should get high flow oxygen. Pale, cool diaphoretic skins, rapid heartbeat, a low blood pressure. These people should get another, whatever it might be, some high flow oxygen levels. We're not worried about free radical release in these people. They need oxygenation. And this would include people like major trauma patients, gunshot wounds, and major car accidents, things like that. And any patient who has what you would determine as a severe respiratory distress. So this would be the severe asthmatic, the severe COPD patient. Their saturations are well below normal. So with the asthmatic, if it's below 90, the chest pain patient, if it's below 90, they would get oxygen, high flow oxygen more than likely. If you have a person who's a COPD patient and their normal oxygen saturations are 90% or 88%, and now they're 78%, that's a severe change. They need oxygen far above what they would normally have at home. Now, oxygen is provided in these compressed air cylinders. No matter what size the tank, it's going to hold 2,000 psi. It's just the volume of gas in liters. The most common portable tank is called a D tank, a Delta tank, and it holds 2,000 psi when it's full, and it holds about 350 liters of volume of gas when it's full. The M tank, which you see built into or fitted into the ambulance there on the right, that's also has 2,000 psi when it's full, but it has 3,500 liters of volume. So it lasts a lot longer, but in all cases, when they're full, they're 2,000 psi. When we change them out, swap them out for full ones, depends on your agency's policies and just common sense. So if you have a D tank, the little portable D tank, if it gets below 1,000 psi, it should be changed out. That way you'll have sufficient oxygen for the next call. For the tanks that are bolted into the ambulance, the M tank or the G tank, those should probably get pulled out when they hit about 300 or 400 psi left. That's usually the policy of most agencies. Again, you just follow whatever your agency wants you to do. Just don't let them run down to zero, basically. Now, oxygen promotes combustion, so no smoking around there, no petroleum-based products, because that can cause spontaneous combustion. And of course, you want them, they have to be legally, by federal law, they have to be secured in some manner, whether it's in your airway bag or attached to your gurney or attached to some type of support system in the ambulance. It has to be supported from not flying around, because you have this 2,000 psi compressed gas in this metal cylinder. The valve could break off, and now you have basically a possible injury to someone. This thing's flying around and hit somebody. So along with these tanks, we have pressure regulators, and this is a common brand out there. You can see the components of it. There's a gauge that shows the psi in the tank. That's the round gauge with the little needle on it. And then on the right side, on the end of it, there's a little black dial, and that's your liter flow adjustment. And there's a little round window where it says off right there. If you move that black dial, you can go to 2 liters and 4 liters and 6 liters and 8 liters, or whatever you want to go, up to usually 25 liters is the max in that case. And you'll attach your oxygen delivery system to that little nipple where that guy's putting in the tube. That's your low pressure side. Some regulators also have a high pressure side, which is a threaded nipple. As you can see, the green tube is being threaded, or has been threaded onto that high pressure side. That flows at 40 liters per minute, and that's used for things like some kind of oxygen-powered device to provide artificial ventilations, or if someone's using CPAP, that's where you would attach the CPAP device to, and I'll cover CPAP here in a couple of minutes. Now, the 2 most common oxygen devices we'll be using in the field is a non-rebreather mask and a nasal cannula. Now, the NRB, or the non-rebreather mask, runs at 15 liters per minute. So you would turn that black little dial to hit 15, turn the tank on, make sure the tank is full, turn that to 15 liters per minute, and at 15 liters per minute, this mask provides 90% oxygen to the patient. Now, it's called a non-rebreather because technically there's little side vents, and as the person breathes out, his exhaled air exits the mask. But it's not completely that efficient, so he only receives 90% of the oxygen, not 100%. The patient breathes from the reservoir, the inflated bag that you see there in the picture at the bottom of the mask. So what you'll do is you'll attach this mask to the regulator. You'll turn on the tank. You'll set the regulator to 15 liters per minute. You'll ensure that the bag is inflated prior to applying it to the patient. It usually will automatically inflate by itself. It might need a little assistance, but in most cases it inflates by itself. You then place it on the patient, securing it, make sure that the seal is nice and tight. Now, if they don't need high flow O2, or if they cannot tolerate the mask, you can put them on a cannula. Cannula goes, there's two prongs go in the nose. The strap goes around the ears and under the chin, as you can see from the picture there. And this flows at a rate from 1 to 6 liters per minute. Again, you're going to attach this to that low pressure side. You're going to turn that black dial to 1, 2, 3, 4, 5, whatever, 6 liters, up to 6 liters. We usually start out at 2, seems to be a good place to start, and we titrate up as necessary. At 6 liters per minute, the nasal cannula provides 44% oxygen to the patient, and that includes the 21% room air and the extra oxygen that the person's getting from the cannula. Each liter that you apply adds about 3 or 4% additional oxygen. So at 2 liters per minute, you're adding about 8% more oxygen than normal room air. And these are great devices for those people who their saturations are above 90%, but they're just not quite above that 94% that we want. And this is a good way to titrate. Start off at 2 liters, give them a couple of minutes. If they don't improve, you can go to 4 liters, and then if they don't improve, maybe go to 6 liters. And if that's still not working, then maybe you could then bump it up to a non-rebreather at the 15 liters. So again, start small and work up. Now, I mentioned way back when in this lecture about children who have croup-like cough. And this is what I was talking about with the nebulized treatment. This is a nebulized tea and a nebulized mask. EMTs, I believe, carry nebulized teas. I've seen masks as well. You can actually modify and make one of these up pretty much in your ambulance. But what happens is normal saline or just some type of water. It could be still water. It could even be Sparkletts water, whatever you happen to have, will go into the medicine chamber. See the little green space, little plastic thing in there? That's the medicine chamber in there. This gets hooked up to your regulator, the low pressure side. It's flowed at low rates, 4 to 6 liters for the nebulizer T, the one on the upper right, and then 6 to 10 on the mask version down below. And what this does is it takes the oxygen, it humidifies the oxygen, and this person is breathing in this humidified gas, which relaxes the back of their throat, which reduces that croup-like barking sound that you might hear when they have this problem. It's a county protocol, it's standing order. It may be repeated as needed. Other devices that you'll encounter in the field, and my recommendation, if you go to a convalescent home or a medical office and you see people with these different types of in-hospital masks, take them off and replace them with what you would normally use on this patient. So if this person has a simple face mask, essentially is a face mask without a reservoir. A partial rebreather is something that you can adjust. A Venturi mask is adjustable as well. A tracheostomy mask goes right over the trach, the hole basically in their throat because they have a stoma or some type of trach appliance. Again, I would recommend, I've seen some pretty horrible things. I've seen skilled nursing facilities, they'll flow a non-rebreather mask at 2 liters per minute, and I've seen them flow nasal cannulas at 15 liters per minute. So, don't rely on what they've applied. I would definitely take it off and apply what you should be using from your own airway bag. This is the CPAP. This is continuous or constant positive airway pressure. And what this does is it's kind of like taking a vacuum cleaner and putting it on blow and then putting it to your mouth and just shoving air down into your lungs at a fairly moderate clip, so to speak. And what it does is it opens up your alveoli, it opens up your bronchial tubes. This is really good for people who are like drowning patients, congestive heart failure patients. They aren't quite yet ready for the bag valve mask, but they need more help than a simple non-rebreather mask. They need some assistance with opening up their lungs by this extra pressure you're creating in this device. The thing about all this is they need to be awake, alert. They can't be tired. They can't be worn out. They can't be uncooperative. They cannot be unconscious. They have to have this need, but they also have to have some fairly decent tidal volume as well. So if you find somebody who has having congestive heart failure or an asthma attack, you see accessory muscle use, the saturations are below 90%, and they are in respiratory distress, maybe in moderate respiratory distress, but they're awake and they're alert and they're cooperative, this might be a good candidate. Maybe you've already tried a non-rebreather mask without any kind of results. It hasn't improved with the 15 liters per minute. This would be a bump up into the next step up just prior to doing bag valve mask ventilations. So these are set at different flow rates. Some of them will start at 5, they'll go to 7.5, and then 10 centimeters of water. This is the amount of pressure being pushed into the lungs. The max flow rate is 10 centimeters, about the safest you're going to get. And it might take the patient a few minutes to get used to this device. It's rather uncomfortable. It's rather loud. It makes a loud buzzing sound. And if you are short of breath, think about it from your perspective. If you were short of breath, would you want me to come in and cover your nose and mouth with this constrictive mask? So you got to work with the person. Usually what I do is I'll start the person out on a non-rebreather mask. I'll set up the CPAP. I'll turn it on. I'll let them hear it. I'll put it in their hand. I'll have them obviously take off the other mask and place the CPAP mask on their face, letting them hold it to their own face. And once they get comfortable with it, and once they realize that, yes, this is helping me, that's when I apply the Velcro straps to hold it in place. So it takes a little while to work with them. Watch them closely. If they start to nod off, they look like they're getting tired, or they look like they stop breathing, take off the CPAP and go right to BVM ventilations. They're just tired. Now, when it comes to the definition of inadequate breathing, essentially what it comes down to is if their rate is ineffective and or their tidal volume is inadequate, this person's having serious difficulty breathing. It can be one or both of those. So when it really comes down to, and I know you learned about ventilation perfusion ratio in your anatomy, physiology, pathophysiology lectures, but basically what's happening is either not enough gas is getting into the lungs to exchange, or not enough blood is returning to the lungs to pick up that gas, or sometimes both. One way or the other, this person has this mismatched ventilation perfusion ratio, and they're not getting enough oxygen into their bloodstream, and they're not able to get rid of the carbon dioxide. So their pH levels they're becoming more acidotic. The pH levels are dropping. Their oxygen saturation levels are dropping as well, and you have a very serious condition to the point where if it's not resolved in some way, they can get seriously harmed by this or even die. So obviously, if this person's beyond a CPAP, they're not breathing effectively, it's way too fast or it's way too slow, they're unconscious, their tidal volume is ineffective, their chest isn't rising and falling anymore, they need positive pressure ventilation with a bag valve mask or even a mouth to mask, I guess, if you're not on duty. There's one person and two person methods. The most efficient, of course, is the two person because the seal can be maintained by one person while the ventilations are provided by the other. And again, with pediatrics, this is the only way we're doing it now. Again, with that jaw thrust maneuver for pediatrics. Now, when someone's breathing spontaneously on their own, they're breathing in room air. And by expanding their chest, the pressure inside their lungs decreases, causing air to rush in, and then the oxygen is absorbed. And then when they relax their chest and their lungs contract, the air is pushed out against the atmospheric pressure, whatever it might be at sea level. So the point I'm making in all this is that normal spontaneous breathing, the amount of pressure that your lungs that is exerted on your lungs is minimal. It's whatever the atmospheric pressure is you're basically standing in. On the other hand, when you take out your bag valve mask and you start providing positive pressure ventilations to a patient, like you see in this picture, you're exceeding that ventilation pressure exponentially. And you have to be really careful because if you overventilate, you ventilate too fast, too forcibly, too deeply, it actually can harm the patient. And that's why we say just squeeze the bag until the chest rises, allow the chest to fall, the person to exhale, and then perform the next ventilation in whatever time frame fits that person's size and age and all that. Probably when you run in with all this thing is that if you hyperventilate this person too deeply and too quickly, the amount of air, there will be an amount of air that will get into the lungs, but all the other excess gas is going to wind up in the stomach. So it's going to cause gastric distension. Also, because you're increasing the interthoracic pressure by forcing all of this air into their lungs and all this pressure into their lungs, it actually reduces the blood flow to the lungs. And if you reduce the blood flow to the lungs, less blood arrives for exchange of gases, and less blood makes it back to the heart. So ultimately, if you're overventilating, you're actually reducing their cardiac output and you're actually making them hypoxic. And on top of that, you're filling their tummies with air, which is another big problem. So again, good tight seal, two-person BVM is optimal. And if you are the person squeezing the bag, count, one every 5 seconds, one every 6 seconds, one every 3 seconds, whatever the appropriate rate is for this patient. And just make sure you squeeze the bag only until the chest rises about 1 inch or so, and then allow it to fall, wait that number of seconds, and then provide the next ventilation. One thing this does provide, or what's really necessary, is good concentration. And that's why if I'm on a call with someone who's being ventilated, I'll assign the person who I think has that maturity and concentration to perform this skill. It's not something you can, give to somebody who likes to stare at the squirrels and stuff like that. If this person is breathing ineffectively, it's way too fast or way too slow. You see this with people who are asthmatics. They're breathing at 50 or 60 times a minute. Congestive heart failure patients the same way. Stroke patients can be breathing really slow, 4, 5, 6 breaths per minute. Drug overdoses possibly as well. Trauma, head injuries especially, they have these really fast, irregular respirations that are caused by the massive head trauma. All these people that are breathing on their own, but the breathing is not effective, they need positive pressure ventilation. You have to decide whether you're just going to override their breathing completely, just ignore what they're doing and do your normal once every 6 seconds or 5 seconds or whatever is appropriate, or you're going to assist and intersperse your ventilations in conjunction with their ventilations. And it really depends upon the individual patient how slow they're breathing, and if you have time to intersperse your ventilations between their breaths. If they're breathing really fast and really shallow, you can't really in any way follow their ventilation. You just have to do your own thing and just override their breathing with your bag valve mask. These are normal rescue breathing rates. You should already know these. This is 10 to 12 breaths per minute. For adults, 12 to 20, once every 3 to 5 seconds for pediatrics, and of course newborns, 1 to 1.5 seconds apart. And this is if someone has a pulse, essentially. And again, on this infant you see in the picture, ideally you'd have 2 people doing a jaw thrust, one person doing the jaw thrust and holding the mask, and one person squeezing the bag to get optimal ventilations on this young child. Other things you're going to encounter out there, the first thing is fairly common, especially for EMTs, is you're going to encounter people with stomas and with trachs. You can see the BVM attaches right to the trach appliance, and the stoma, you can take I'm sure you learned about this, you can take an infant mask, a BVM mask, and attach it to your BVM bag, and then you can place the mask over that hole and ventilate through that hole using the child mask. If the person's breathing spontaneously, they have good tidal volume, but they just need a little bit of oxygen, you could take a non-rebreather mask, set it at 10 liters, and just place it around their neck, the strap around their neck, and have it hang right next to or below the hole. You give them blow-by oxygen that way. It's another way of doing that. And you can see again, there's this ventilation through the trach tube. Not all tracheostomies are complete, meaning that if they don't have a complete dissection of the trachea, they could have a partial, which means as you're ventilating their trachea, their trach tube, you might hear air coming from their nose and mouth. That means they have an incomplete tracheostomy. So you might have to actually put a mask on your BVM, ventilate through their nose and mouth with a nasal pharyngeal airway or oral pharyngeal airway, and then cover the trach appliance and ventilate that way. It's probably easier than trying to do it the other way. Of course, you already learned about airway obstructions. If they're awake and choking, you do the Heimlich maneuver. For babies, it's 5 back blows and 5 chest thrusts. When they go unconscious, you would just start compressions and ventilations like you would with a CPR. The only difference is that between your compressions and ventilations, you would look inside the mouth for any type of airway obstruction that might have come free during your compressions. Because remember, doing your proper chest compressions might force that object out of their lungs or out of their trachea and up to where you can see it, and then you can remove it. And then lastly, automatic transport vents. These things are people that do have trach appliances. These are home devices. They're battery operated. They can also plug into basically a regular 110 circuit in the ambulance or in the home, obviously. Sometimes they're attached to oxygen, sometimes they're not. Sometimes they're done on room air, depends on the circumstances. Usually the parent or the caregiver knows how to operate these. If you have a situation where you have to take someone to the hospital and they're on a vent, you should have the person who knows how to operate this thing come with you in case it fails, or know how to adjust the volume and the rate and all that. If en route to the hospital or if at scene the ventilator stops working completely, you would have to remove the vent tubing and then take your BVM and then artificially ventilate them with a BVM. So you should always, if you have a vented patient like this and you're transporting them to the hospital and they have a ventilator that's working, you should probably have your BVM sitting somewhere within arm's reach, just in case they do stop, this device does stop functioning. And we're done with the airway chapter.